Welcome to the PA Insights podcast, powered by NCCPA, the show where we explore the people and stories shaping the PA profession. Today's episode is brought to you by the partners in the Mental Health Initiative sponsored by the NCCPA Health Foundation. In this episode, we're sitting down with two experienced PAs, Jay Summers and Todd Allen, both of whom have built their careers in psychiatry and mental health. Jay shares how a background in philosophy led him to explore medicine's big questions, meaning, purpose, and the connection between both the mind and the body. Meanwhile, Todd talks about how an unexpected psychology class and a lucky job offer turned into a lifelong passion for helping people heal from the inside out. Together, they open up about the challenges, rewards, and emotional realities of caring for patients in mental health, and what it truly means to listen as a clinician.
All right. Well, welcome to the podcast. I'll introduce myself first. My name is James Summers, but I go by Jay. I've been a practicing PA since 1998, graduating from Rosalind Franklin University in Illinois, and started out in family medicine, internal medicine for about 4 or 5 years out of school, and transitioned into psychiatry after that. I kind of worked inpatient, outpatient, state hospital settings. In 2022, I earned my Doctor of Health Science degree from A.T. Still University, and kind of working on professional fulfillment and burnout, especially in kind of provider bases, is really my focus. In recent years, I've developed a strong interest in lifestyle medicine, so the role of sleep and nutrition and social connection, substance misuse, things like that in medicine. And I've been able to lecture nationally on this, and it's been very, very exciting to learn so much about it and to interact with such great people. I currently still practice clinically in Las Vegas, Nevada, and I've also started to do some part-time work with the University of Lynchburg in their Doctor of Medical Science program, and that's been a whole new environment to learning how the education side of PA education goes, and I've been able to learn from some great experienced educators there. So I'm going to hand it over to my co-host, Todd Allen, for him to introduce himself. Todd, why don't you tell us a little bit about yourself?
Yeah, so my name's Todd Allen. I've been practicing as a PA since 2012. I actually graduated from the Midwestern University PA program down in Glendale, Arizona. Unlike Jay, I've done psychiatry basically my entire career. I did have a couple of years where I did work in an urgent care setting on the weekends and stuff, but I've basically done psychiatry my entire career. What that has looked like for me is I've worked in the state hospital in Idaho. I've worked in corrections medicine, doing psychiatry for those individuals in the correctional setting. I also have an outpatient clinic that I see patients in that particular setting and stuff as well. I do that 1 day a week. And then more recently, over the last couple of years, I have gotten involved in more like addiction type medicine and stuff. So working with those people that struggle with addiction and with just their basic general mental health issues and stuff as well. But I've really kind of been in all areas of medicine related to psychiatry and stuff like that. So I guess I could say I've been there, kind of done that when it comes to that. So
excellent. Well, I'm excited to learn more about this. Well, why don't we kind of jump into the questions? You talked about it a little bit, but tell me a little bit about like how you got into psychiatry, what experiences led you to decide on psychiatry as a field.
Yeah, so my route into psychiatry was a little bit different. I remember when I was in my undergrad program, I had to take Psychology 101, and then when I decided to pursue a degree in to become a physician assistant, I needed to have some prerequisite classes. So I'm looking at the social sciences and stuff, trying to figure out where else can I go, what else can I do, and sociology did not even sound interesting to me. So I'm flipping through some of the psychology course offerings and stuff, and I stumbled across one that is abnormal psychology. And it was in that particular class that it started talking about the serious mental illnesses, started talking about depression, schizophrenia, and those types of things, schizoaffective disorder, and really kind of opened my eyes that there's a lot to psychiatry or mental health that I was unaware of. And it really did spark my interest at that point. But I have to admit, when I was out there and I was going through the PA program there at Midwestern, psychiatry was not on my radar even at that point. I figured I was going to end up in surgery or emergency medicine, the glamorous areas of medicine. So when I was getting ready to start applying for jobs, I had asked one of my preceptors, of course it was my preceptor for my mental health rotation, I asked him if he would write a letter of recommendation for me, which he graciously agreed to do. And when I went over to get the letter of recommendation for him, we talked and did the pleasantries, how you doing, how's the rotations, yada yada yada. And then as we're getting ready to finish up, he asked me what I thought of my mental health rotation. And I thought about it for a second. I'm like, ironically, I really enjoyed it much more than I thought I was going to. And he's like, would you be interested in working here? So I thought about it for a minute, and I'm like, yes, I could see myself doing that. And so I didn't even really have to work at trying to find a job as far as that goes. It just kind of fell into my lap. But I can tell you, after doing this for the past 13 years now, I can't see myself doing anything other than what I'm doing. I love what I do. I have learned that the mental health is all around us, and it doesn't matter if somebody's walking into a family practice setting, if somebody's coming in to see me specifically for behavioral health. It doesn't matter if it's my friends, if it's my families, if it's my coworkers, it's whatever. Mental health is all around us, and I cannot see myself doing anything other than what it is that I'm doing now. So that kind of tells you a little bit about my experience. So share your experience with us about how did you get into psychiatry, and what has kind of pushed you down that path, so to speak.
Yeah, it's a funny thing, because I think I probably had an experience similar to yours in that I certainly never thought about mental health as a field, as a career to go into. When I was in PA school, we didn't have a psychiatry class or a rotation in psychiatry. So, unlike so many exposures that PA students have these days, my experience in psychiatry, really, we, at Rosalind Franklin, we were on the location of the naval base in the Great Lakes in Illinois, and they had a VA right there. And the reality is that my interest in the field, once I learned about it, probably started way before that. I mean, the reality is my undergrad degree, I didn't really talk about it in my intro, but my undergrad was from a little liberal arts school in Illinois called Shimer College. And for the most part, my majors were performing arts and philosophy, right? And the joke is, that I use both of those every day. Right, we think about certainly performing arts and how we talk to patients, how we enunciate, how we express our ideas, but philosophy is really all about the big questions, right? We talk about the objective nature of reality and subjective, how we think about truth, how we think about our brain, how we think about finding a sense of purpose in the world. It was actually Rene Descartes, the philosopher, who first talked about mind-body dualism, right? I mean, this idea that, and I think we've been living with that for a long time, this idea that the mind and the body are completely separated, that basically the body is just this carrying mechanism for the mind, right? And I think that's where a lot of our stigma comes associated with mental health, right? We talk about, that's why we've had such problems over the past hundreds, perhaps thousands of years on mental health. This concept of you're suffering from depression, you're having problems with anxiety or schizophrenia or bipolar because of some deficit in you, but nobody necessarily thinks about that with high blood pressure or diabetes or cancer, right? And so this idea of why do we do the things we do? What is the most important thing, right? And I think that looking at that and talking about why do we think about the things that we do, that was really interesting to me. I've always been really focused on kind of the big questions, right? And to me, psychiatry is the biggest question, right? I mean, why is it that we're here? How do we find purpose and meaning in life? How do we identify something that's really deep and meaningful to us? Because ultimately, that's what all of medicine is about, right? Why do we do anything?
Correct,
we're doing these things because it ultimately satisfies us, right? We find purpose. We find connection with other people. We find, connection with the people we love. We find meaning through helping other people out, right? So that, I think, was really, really meaningful. And in the end, that early experience in college, and then, of course, later on, finding the PA profession and thinking about mental health, as I said, I started in family practice. And of course, we all know that family practice, internal medicine, even pediatrics, right? They, 25% of their practice is psychiatry.
Sure, absolutely.
Right? So that kind of introduction into like, well, why are we treating this, right? I always tell people that when I was in family practice, I was treating people's blood pressure, and I was like, well, your blood pressure is, 160 over 95. Your diabetes is, you have a fasting blood sugar of, 210. Like, we got to do something about this. And they'll be like, oh, but I feel fine. Yeah. I'm like, well, I know you feel fine, but like, you're going to have a stroke or a heart attack, right? But this idea that we spend so much of the time in medicine not really focusing on what people care about, because we're not framing that conversation well enough, right? In the end, they care about the fact that they can't walk up a flight of stairs, or that they're going to have, dementia earlier on, or that they're not going to be able to hold their grandchildren, when they're 60 or 70,
sure.
Right? That's what they care about.
Yep.
And that's what we need to focus on. And really, that's all of mental health. It's all about that, trying to be excited and identify what matters to people when
sure.
you talk to them about that.
Okay.
So yeah, that has been the case. And like you, after finding psychiatry, I can't imagine that I would ever want to do anything else. It's such a flexible field. It's obviously really ties in with something that's important to me, which is that quality of life component. And I think it kind of innervates all other areas of medicine.
Yeah. Yeah, no, I agree that you were definitely hit the nail on the head with that one. So you talked about how long you've been out there practicing medicine. Can you kind of tell us a little bit about what obstacles, what challenges you faced over your career, and how was it that you were able to overcome those obstacles or challenges?
Yeah, that's a good question. I think the interesting thing about challenges and obstacles is a lot of times after we overcome them, we don't really think they were challenges and obstacles. Right?
Yep, that's true.
We think about like, oh yeah, that wasn't that big of a deal, right? But I think, as I think back to my early career, I said that I was in family practice for about 4.5 years before I transitioned into psychiatry. And, I was in psychiatry kind of part-time and then went full-time, after a year or two. And I remember in a I guess it was probably my first year in psychiatry, maybe my second year part-time in psychiatry. I was doing this initial workup on a patient, a gentleman who was suffering a major depressive disorder. And first time I had seen him. And at the end of the session, I was walking him out to the waiting room, and he stopped me in the hallway and he said, you just don't get it. You don't understand. And I immediately became defensive, and I immediately said, oh, but, this is what we're doing, and this is why I'm doing this. And I realized that it was true, right? I didn't get it, because what I was doing was I was approaching psychiatry from a perspective that I approach family practice, which is that there's a problem to solve, right? That, okay, let's follow the algorithm. Let's look at the DSM, right? We're gonna find the right drug for you, right? Okay, this is what your blood pressure is. This is what your blood sugar is, right? In family practice and in some of the others of medicine, it doesn't really matter how the patient feels, right? Like, yep. You have cancer, you have diabetes, you have high blood pressure. In psychiatry, all of that is thrown out, right? In the end, if you don't believe you have depression, guess what? You don't have depression, right? Yep. Barring psychosis and things. But in the end, these things are meaningful. They really help me focus on the fact that what people need in psychiatry is to be heard, right? They need to be heard. They need to be understood, and we need to work on the things that are important to them, right? We need to work on how we address those issues, right? I always tell people, in psychiatry, when I sit down with them, this is not my journey. Right? I don't have any way. I can quote the DSM and I can give you timing and severity and criteria, but in the end, the criteria on the bottom of every DSM, a diagnosis is, And this is significantly impairing of social and occupational and other areas of functioning.
Sure.
Right? And how do we define that? Well, I don't define it. Right? I mean, in the end, that is the patient's ability to define. So how we think about that and how we feel about those things, I think, is really, really important. Right? We need to make sure that we're paying attention to the patient each step of the way, because this is their quality of life, and that's why we're here.
Sure.
So, but tell me a little bit about, maybe some of your early experiences since you started in psychiatry. Like, how did you, what are the things you really found, especially in that, first maybe 5 years of your career that you had to overcome?
Yeah, so for me, it was a little bit different. I started out in a state hospital, and so things are a little bit different in that environment, because if somebody comes into a state hospital, or in the state that I work in, someone comes in the state hospital, you don't really get a choice whether or not you want to be treated for your illness. I mean, you've been committed there. A judge has said you have to be there. And so the first few years that I was in practice doing, state hospital stuff, it wasn't really much of a challenge. It didn't have many obstacles. Really, the biggest challenge for me was when I would get a patient stabilized in the hospital, then I would discharge them to the community, getting them to adhere to the medication. It's easy for me to see them walking in when they're acutely psychotic, acutely manic, or in some kind of a decompensated state. It's easy for me to see what they look like. And it's easy for me to see, okay, I prescribed medication X for this patient, and after working with them for several weeks or a few months or whatever, they look like a totally different person when they walk out the hospital. I can see that. They can't always see that. And so to try and convince them, or, show them that they are doing better and that the medication was the reason for why they're doing better, that really is a challenge. Now, that's not just going out of the state hospital. Even working in my outpatient practice and working in my addiction medicine practice and stuff, it's the same thing, right? People come in and they say, I don't feel right. I don't understand what's going on. I say, well, this is what I think you have going on. Here's a medicine. It should kind of help you manage some of those emotions. You manage those mood swings and stuff like that. And then they come back in and see me. I said, how you doing with the medication? I was like, well, I didn't like the way it made me feel, so I stopped taking it. Well, did you feel better? Well, yes, I did, but I didn't like the way it made me feel, so I stopped taking it. And so to try and convince them or show them that the medication is the reason for that. And it's okay if you don't like medication X. I have other medications that I can use. You just need to be able to communicate that with me. Same thing with addiction medicine. Somebody comes in and says, look, man, I have stopped using, heroin, 2 weeks ago. I'm really struggling right now. Can you help me? Sure, absolutely. And so I give them, some medication to help with those cravings, or to help with withdrawal symptoms and stuff. And as soon as they're over the initial hump, all of a sudden it's like, I don't need the medicine anymore. So they stop taking the medication, and the next time I see them, it's because they relapsed. And they're back in because they're in the same situation they were before. So there definitely are some challenges to doing mental health, medicine and stuff like that. But the challenges that I faced have been a lot different than some of the other providers out there and stuff. Dealing with mental health is an emotionally draining field of medicine for the provider as well. That was one of the things that I really had to work on, focus on, for me, was being able to separate work from home. Because when you're dealing with these severely mentally ill patients and you hear their stories and you see where their lives are at and what has happened to them in their lives and stuff, it's hard not to get invested in your patient. And so when your patient isn't doing well, that puts stress on you, which then can affect other areas of your life. So for me, that is probably the biggest struggle that I had, or the biggest challenge that I had, was being able to separate work from my own personal life and recognize that, this is what I do at work, but when I'm at home, I don't have to think about what I'm doing at work.
This is just the beginning of our conversation with Jay and Todd. In our next episode, we'll dive deeper into whole person medicine, how PAs integrate physical and mental health, collaborate across care teams, and find fulfillment in a field that is as demanding as it is meaningful. Stay tuned for part 2 of the PA perspective on mental health.